Hello, welcome to our webinar on pregnancy and postpartum mental well-being. I'm Tessa Weegen. I'm a mental health planner with the Minnesota Department of Health, and I'll be your speaker today. Today we'll be talking about what is perinatal mental health. We'll go through some definitions and understanding about what it is. We will talk about how postpartum mood and anxiety disorders affect the family, the baby, the caregivers. We will also discuss how providers screen for this. What do we do to look for perinatal mental health concerns, and what help is available? When we talk about perinatal mood and anxiety disorders, it's become the new terminology or words we use to discuss a whole variety of mental health concerns that can happen related to pregnancy and birth. Postpartum depression and anxiety are the very, very common symptoms or complications, if you will, of pregnancy and birth. So we also know that for a long time we talked about maternal depression as an issue, but more and more we're recognizing that anxiety and crippling anxiety that makes it impossible to live your life in your comfortable and normal way is just as much and with many women more of a problem than depression, and also that it's not something that just happens in the postpartum period. When we talk about postpartum, that word means the time after the baby is born and is usually meant to refer to from the birth of the baby to 12 months out. That's considered the postpartum period. Prenatal is, of course, the time when the mom is pregnant. And so perinatal is a word that encompasses both pregnancy and the 12 months after. So the perinatal period is about 21 months long from pregnancy to the end of the first year of the baby's life. When we talk about perinatal mood and anxiety disorders, we can be talking about a variety of different mental health concerns that can affect. We mostly talk about women because we're primarily talking about the mom as the person who's experiencing this disorder or mental health concern. And we'll talk a little bit about how it's not just moms later, but for the sake of ease, we'll talk about it with moms. So we can be talking about prenatal or postpartum depression, prenatal or postpartum anxiety. We'll talk a little bit about postpartum psychosis, which is certainly the most severe, one of the most severe things that can happen. And we'll also touch on intrusive thoughts. When we talk about these disorders, it's a big deal because it is disruptive to care for yourself and for others. It isn't just that you're feeling a little sad. It's that depression or that stress or anxiety level is making it impossible for the person to do the things they need to do to care for themselves and others. And like I said, and I'll refer to this a little later, it isn't necessarily a hormonal thing. We've, in the past, really thought about this as something that like the act of birth made this happen for a mom, the act of that, the different hormones that are happening within a mom's body during pregnancy and birth. But we know that these disorders or these concerns can happen with an adopted mother. They can happen with a father. It can happen with the primary caregiver. And so it isn't necessarily related to the hormonal changes of birth. Even a mom or a dad who did or didn't give birth could be experiencing it. And people can also experience it even without having a live baby. So another thing I want to just add is that postpartum depression is not the same as baby blues. Baby blues is sort of the overwhelming experience that happens within that first week or two of having the baby. It happens to about 80% or more of moms after they have a baby. So it's really, really common. And it sort of looks like crying or irritability, but it doesn't interfere with the mom's ability to care for the baby, and it also stops. It takes care of itself within a couple weeks. When we talk about postpartum depression or anxiety, we're talking about something that doesn't take care of itself. This impacts a very low estimate is 10 to 15% of new moms. We know in high-stress communities, that's more like 30 to 35%. Again, the thoughts, tearfulness, feelings of sadness or irritability, major mood swings, but it can include thoughts of harming herself or her child. It can occur anytime within those 12 months. That's the postpartum period. And the symptoms do persist. That means it doesn't go away, and it does require treatment of some kind for the mom to get to a better, healthier place. The effects of postpartum are serious. It's not just, oh, mom is sad. There are things that actually impact the child's development. For the mom itself, depressed moms and They haven't done as much research on anxious moms, but certainly depressed moms are less likely to breastfeed, but they're also more likely to not take care of themselves well, to not follow through with their own health care, to not get their postpartum visits. And they're also really at increased risk for treating that depression on their own through substance abuse or other risky behaviors. And they're certainly at a higher risk of depression and future suicide. On children, we're going to go into another slide that talks about even more about the effect on children, but overwhelmingly, or sort of as an overview, the effect on the babies can be sleep delays, developmental delays, and just general risk to the infant's mental health. So there's been a lot of research actually on the effect of maternal depression on the baby. And just briefly, in prenatal, so this is when moms are having depression when they are pregnant, we see that they don't get the same prenatal care that they need. They have poorer nutrition. This leads to higher preterm birth, babies being born early at lower birth weight, and higher rates of preeclampsia and spontaneous abortion. For the infant, we can see issues around behavioral. The infant may not bond in the same way that another infant would bond. We could see an anger or protective style of behavior from the baby, or passivity, withdrawal. They may not look to bond with a caregiver because they haven't been receiving that from their primary caregiver. And we can also see lower cognitive performance. So the baby is not developing mentally the same way as other babies. As a toddler, you'll see a passive noncompliance, which really means the toddler's not listening and not behaving, but not really acting out. They may just be less mature, less able to act out, or less able to explore or find things on their own, and just less interaction with others, both peers and caregivers, and less in their mental health side, less creative play, less trying new things because they're not feeling as confident and supported. In the school age, so in elementary children, we'll see ongoing effects with impaired ability to deal with problems, impaired ability to connect with other people, higher anxiety, and academically that looks like perhaps attention deficit disorder and lower IQ scores. And this, we can see repercussions of untreated maternal depression all the way up into adolescence, when we see more cases of depression, anxiety, phobias, panic, substance abuse, and alcohol abuse with adolescents who had untreated maternal depression with their caregiver. And again, that looks like academically attention disorder and learning disorders. And I want to be clear that these are common effects of maternal depression when the mom is not being treated for depression on the child. It doesn't necessarily mean this happens with everyone, but these are concerns that are very real. And I think what's important about this is when you are talking to a mom or to a family about maternal mental health, it may be easy to say, oh, it's not important. I'm sad, but I'm taking care of the baby, or I'm sad, but it's just supposed to be hard. And I think the emphasis here is, yeah, it's hard, but the depression and the effects of depression upon the baby and the relationship between the mom and the baby are a big deal, and they may cause serious problems. And the reason why we're talking about and looking at it is because it can be treated. It isn't something that people just have to power through or deal with. So we're going to talk a lot more about treatment in a minute, but first we're going to talk more about the other types of mental health concerns that pregnant or postpartum moms might have. So perinatal anxiety disorders, we think anywhere between 9 to 30% of women. This is in some ways harder to understand or to assess, because certainly when you have a new baby, being stressed out or being anxious about that new baby is appropriate, right? You have a little tiny thing here and you have to take care of it, and that's a scary thing for people. Where this kind of crosses the line between just normal stress or dealable stress of having a new baby is when it becomes something more overwhelming and really impacts the ability of the parent to act as a parent and act in their normal way. So if you look at people who are maybe, and these are small examples, this isn't necessarily true for everyone, but obsessively cleaning, obsessively scheduling, scared to leave the house, scared to deal with just the general day-to-day activities. And certainly if you're finding moms or caregivers who are not sleeping, who are just so stressed out and anxious that they're not able to sleep, those are really clear signs that there is an anxiety disorder happening. And just even to back up and say that these can be time-limited experiences. Someone who's experiencing an anxiety disorder right now can be treated, and it doesn't have to be something that's with them their whole life. And I think as you introduce the conversation with a mom about mental health, it can be very scary to think about, oh, I have anxiety. Does that mean I always have anxiety? Well, not necessarily. And I think it's as you approach that conversation with moms to be careful to not just say, okay, I diagnose you officially, you're depressed. That's not the role of the community health worker. The community health worker is helping moms to understand that it might be an issue enough to help mom get to a different place where a doctor and a medical provider can help them understand what their issue is and what their treatment looks like. So let's talk a little bit about how prevalent this is in Minnesota. Now, these statistics come from what's called the Minnesota PRAM study, or the Pregnancy Risk Assessment Monitoring System. This is widely done. It surveys a lot of women right after they had their baby, but it is self-report. So we only get the information back from women who choose to fill it out. So that does impact certainly the responses. But as the questions that were asked around depression basically ask, did a provider say you had depression? Did you feel like you had depression after your baby? And so we're, again, talking about just that postpartum period and just depression. But within that category, statewide, we had 9.2% of moms saying yes to that question between 2009 and 2011. And that number increases significantly among our Black and American Indian moms, up to 14.4% and 20%. We also see a significant difference when you look at education level. Moms with lower education, less than a high school degree, are significantly more likely to experience it. But all of these numbers are less than what the national data says that we should see in our population. So again, that's a 12 to 15% and up to 35% in high stress situations. This is just the bare minimum that we know from self-reported data. Another way that we can understand it is by looking at the billable data. So the Minnesota Department of Human Services, or DHS, is where all of the information from all of the billing for any healthcare appointments that people have that were paid by Medicare, for people on medical assistance. So it's not all moms, it's people on medical assistance, which means people under a certain poverty level. But if we look at, if you look below, you can see 2011, 2013. These are the rates for moms who had a diagnosis of postpartum depression on their record within that first year of the baby's life. And so we see in this population in Minnesota, somewhere around right about 18% of moms. So changes a little year to year. Now, of those moms who had a depression code within their record, only about half, and I mean, there's a difference here, 63% to 50%, but somewhere around half of those moms received any sort of billable mental health treatment. That means about 50% did not. Now, we don't know what kind of other supports they received, so they may be getting help from their mothers, from their churches, from their mosques, from community groups. Those would not be considered billable treatments, but as far as therapy or medications, only about 50% of moms receive those. So thinking again about who are the moms that are likely to experience this anxiety or disorder, here are some risk factors. So moms who would be more likely to experience it. Those who have a previous history of depression or anxiety or other mental health concerns. Moms who were infertile or had preterm labor. Infertility is actually a really interesting connection here because if a mom had been infertile for a long time or had a hard journey to get pregnant in the first place, then there's an additional sort of outside pressure and internal pressure that she's supposed to be very happy that she has a new baby. And so if she doesn't experience it that way, it can make the depression even stronger. History of a sexual abuse, traumatic birth. And this traumatic birth is a very subjective thing. It really depends on what the mother considers traumatic birth or the family. If they thought it was going to be one thing and it happened a different way, that may be considered traumatic birth for the mom, even if someone else would say, oh, well, you have a healthy baby. What are you talking about? Well, for them, it was a traumatic birth. Loss of the mom's mother, or who would be the grandmother in the life, previous miscarriage or stillbirth, difficulty breastfeeding, breastfeeding is really interesting around mental health, and especially the depression or anxiety, because breastfeeding is hard, and starting breastfeeding can be difficult, and for some women. And so that act of trying to get it going in the beginning can contribute to feelings of anxiety or depression. Once it's working, once the mom is successfully breastfeeding, then it actually is a protective factor. It can actually, the hormones and the experience between the mother and baby can actually protect against poor mental health. But it's such a tricky thing because it can provide difficulty in the beginning. During it, it's really great. And when moms wean, when a mom stops breastfeeding, that can also be a time that depression can come in because of the hormonal changes. Failed birth plan, which is kind of the same as, not the same as traumatic birth, but different. It didn't work the way you want. Additional issues like retained placenta can cause hormonal changes. Other life changes are psychosocial stressors, financial stressors, issues like that. Perfectionist traits, moms who thought or think that they can reach a superwoman mom kind of a image, or history of body images, especially eating disorders, and other symptoms of mental health concerns during pregnancy. So these are risk factors. It doesn't mean that someone who has these things will automatically experience perinatal mood disorders, but they could. It might make them more likely to. Intrusive thoughts is a really interesting thing. So I wanted to kind of comment on it because intrusive thoughts can be highly troubling to a new mom, but it's not something that they're going to often identify as depression or anxiety. So intrusive thoughts, just to define it, intrusive thoughts is kind of this concept that all of a sudden a thought comes in mom's mind, I'm going to drop this baby. Or basically it's a jarring, sudden thought of something scary, and usually related to the baby or the mom. So I'm feeling like I'm going to drop the baby, or my husband's going to leave me, or I think I'm losing my job tomorrow. They're thoughts that are not necessarily, like it's not, they could never come true, but it's things that aren't happening right now that are very, very scary. And it's important to note that intrusive thoughts don't mean an action. It doesn't mean the mom wants to drop the baby. Most moms, 88% of moms have some intrusive thoughts. The problem with intrusive thoughts is if they're not going away and mom isn't able to settle them. So you may think, oh my goodness, the baby's not eating. We have to go to the doctor. Well, if you can say to yourself, okay, yeah, but the baby ate an hour ago and the baby's probably going to eat an hour. I'm just going to wait and see. Or if you can kind of deal with those intrusive thoughts and figure out what's going on, that's one thing. If that thought is overwhelming and you're not able to get rid of it, that's when we're starting to think about sort of intrusive thoughts as a mental health issue. There's a lot of shame and guilt associated with it because you think, why would I think something this terrible for my baby? Does this mean I'm going to do it? It most likely does not mean you're going to do it, but it's very scary. So there's some behaviors that mom might start doing that would be a good way to recognize that something is going wrong with these intrusive thoughts. If mom cannot stop checking on the baby, cannot stop structuring things, is hiding knives, is hiding medication so the baby can't get hurt, is sort of really over protecting from anything that would be considered standard or appropriate for a baby. And it really very much hurts the ego, or hurts the idea the mom had of themselves. I thought I was going to be able to handle this, and this is too scary. Intrusive thoughts are a very hard thing to deal with because a lot of moms too don't want to tell anyone that they're thinking these things because they're too scary and they worry that it means that they want to do these bad things to their baby. It doesn't mean that, but it's certainly something that's helpful to ask about because, again, like the other issues, if it's something that's impeding on the mom's ability to care for herself or the baby, then it's something that we need to deal with. Postpartum anxiety is not the same as intrusive thoughts, but I think you can see how they interact, but it's just sort of an overwhelming anxiety that makes moms unable to act in the way that she would like to care for her family. And there is a growing awareness that anxiety may end up being more prevalent or more common in the population than depression. So moms who, for a long time, we've asked moms if they, not a long time, but in many cases, we have had a practice of asking moms if they feel depressed. So there are moms who aren't sleeping and are so nervous they can't leave the house, but they would never say they're depressed. And so we're talking about how can we do better at asking moms, are you that level of anxious? And so there's a tool called the Generalized Anxiety Disorder Screening Tool, or the GAD-7, that is available to help sort of assess whether a mom is feeling that overwhelming anxiety. And just again to stress that there's a difference between a realistic level of anxiety. If you have a mom who has a 1-week-old and is not worried about anything at all, that is unique. But there's a difference between realistic anxiety or stress and crippling anxiety. Postpartum psychosis is probably what we think of most, sort of in the public or in the media when we talk about mental health concerns with pregnancy, because this is what drives it's. First of all, it's very, very rare. So rare in 1 in every 500 to 1,000 births, and it has serious results. 5% will have suicide, 4% infanticide, 86% of the women who have this will have bipolar disorder. It is definitely more common with women who've experienced psychosis in the past. Usually begins in those first 4 weeks. This looks like what people would consider a classic manic episode. So manic means very, very fast activity, and it could be coupled with very, very slow activity, highly agitated, not able to distinguish what is a delusion and what is real. It could be hallucinations. It could lead to putting the mom and baby at risk, and definitely requires immediate treatment, usually hospitalization. It is, I think it's a little bit tricky to talk about this in the context of the other issues, because you don't want mom to think that saying that she is experiencing depression means she's going to have psychosis. They're not connected in that linear of way. It doesn't happen automatically. But it's something to be aware of, because if you do have a mom that's experiencing that, you really need to help mom get help very quick. And I will mention that in Minnesota in 2014 and 2015, we had 15 maternal deaths, which means the death of a mom within the year after the baby was born. And of those, 5 were suicides. And I think we have had at least 2 suicides in 2016. So suicide of a new mom happens, and we need to do what we can in our communities to be able to help moms who are in this sort of crisis situation so that doesn't happen. So then we get to why universally screening. So when we talk about universally screening, that means asking all moms if they're experiencing symptoms of mood and anxiety disorder. We talk about universal because it can be easy to just say, oh, this mom doesn't look good, so I'll ask her. That mom seems fine, so I won't ask her. And that doesn't work very well. We know that tests have shown that using a screening tool, which are specific questions designed to help you identify moms who are in need or have concerns, finds more moms in need or concerns than just generally asking questions or generally going on your how you think the mom looks. And again, we screen because the effects of untreated mood or anxiety disorders are significant. The symptoms persist. It requires treatment, and treatment does exist. There are treatments and support that are out there. And these mood and anxiety disorders are very prevalent in the population and are worse, have equity implications, just means it's worse in certain communities. It's worse with communities of color, and it's worse with communities that have high stressors in their community, such as low income and other just community stress levels. So what does screening mean? Screening means using a validated tool, which is usually, in this case, it's a questionnaire, to ask all moms how they're feeling. So as you do your community health work practice, one thing you can think about is sort of which moms are we if you are encountering moms, you're encountering them in the community, you're encountering them in groups you're leading or in follow-up from a clinic, where are you screening them? Are you going to screen them every time you meet them, the first time you meet them, the first session you have? Is it something you do every few weeks? This is kind of the questions you ask yourself as you're setting up a universal screening program. There are tools. These are all, the tools that we'll mention are all free. They're all online. So you just Google their name and you'll find them. The common ones for depression are the PHQ-9, the Patient Health Questionnaire, or the Edinburgh. It's called the EPDS. Between the two, the EPDS is definitely more appropriate for a postpartum mom. The PHQ-9 is just written for depression. But if you're in the case where you're kind of going to screen anyone who comes in, and the caregiver might be a dad or it might be a aunt, then the PHQ-9 is going to be an easier tool to use, so you don't have to go back and forth between them. The generalized anxiety disorder, or the GAD-7, is the one to use for anxiety. They say in general, screens are most effective about 3 weeks after birth when you're past that baby blues period. But it really suggests that you find a way to be screening at intake the first time you meet the mom, and then at some regular intervals after that. Because we certainly have seen with the postpartum depression, there are moms who don't screen positive at 2 months, who do screen positive at 4 months. So it really isn't something that you want to just do once and then put it off and then not do again. So just talking a little more deeply about the PHQ-9 and the Edinburgh, the PHQ-9 is just 9 simple questions. There is a 2-question version you can find, but either one will work. Again, it's not specific to mom student pregnancy, but it is available in 50 languages. There is a Somali version I can help you find. It's not validated or tested, but it is available, and the link here will show you the Hmong version. And the EPDS, so the Edinburgh, is the one that's more designed for pregnancy. There is a Somali version and an Amharic versions of this. I haven't seen a Hmong one, but there might be. There is a Burmese one if you're working with Karen families. That might work as well. And certainly don't forget the partners. Like we said, the even if mom is the primary caregiver, the dad or the other partner in the family can also experience postpartum depression, which can also have, or anxiety, which can also has impact on the baby and the family. 10% of partners experience symptoms. So ask the partner. Normalize, make it valid. Say it makes sense that you would also be having trouble. And so it's a normal thing. And I want to stress that, it could be hormonal, but another big thing that can lead to mental health concerns is the lack of sleep. And we all know that change in sleep patterns is happening to the whole family, not just to the new baby and the mom. So what do we do when you respond to a screen? So you have a mom or a dad, a partner, but when you look at this screen, there's sort of 3 categories that the response might fall into. You're going to have people who screen with no concern or low concern. They have had one little point, but in general, they're really low. You have people who are moderate. They're somewhere in the middle there. There's a problem, but they're not suicidal. And then you have crisis. You have people who may be suicidal or homicidal. So we're going to talk through how to respond to those 3 areas. So first, I'll go back. For low to no concern, what you want to do here is just provide education. So you can talk about the fact sheet. The education I'm going to talk about are pieces that we have online at the Department of Health website. You can certainly find other education pieces too. But we have a fact sheet, which just talks about what is perinatal mood and anxiety disorders. And we also have the Maternal Wellbeing Plan. The Maternal Wellbeing Plan really talks about what does it mean to develop positive mental health and to maintain positive mental health. So we talk about sleep, rest, connection with others, healthy food, movement, support, things that all of us can do to maintain positive mental health. And we try to give some suggestions about how you might do that with a new baby. We do have this available in 7 different languages. All of these are online, and you're welcome to print and use them as you like. So we have them in Amharic, English, Hmong, Karen, Russian, Somali, and Spanish. And like I said, on the same website from this link, we do just have a fact sheet, which is the facts about what the maternal depression and anxiety is. So treatment. When we think about treatment, there are 3. The best practices for treatment can include 3 different areas. So support, what other supports can we bring in to help support mom and new baby during the stressful first year of life. Psychotherapy, which could include group therapy or personal one-to-one therapy, and medications. These are the 3 kind of areas of support, of treatment that moms who are experiencing mental health concern should consider. It's important to note, though, that this is, that you see here, the order of acceptability to moms. And what that means is a new mom going to do this? So a new mom, and research shows that moms are most likely to accept support and then therapy and then medication. And actually medication is lower on the acceptability sort of ranking than doing nothing. So in general, and I mean, broadly speaking, moms are more likely to do nothing than they are to take medication. So what that tells us is that when we talk to a mom who, if we've screened a mom and a mom is screened high and we're concerned about her, that we need to offer a variety of different options, and that offering just medication when we know medication is the least likely to be acceptable isn't going to work. It isn't going to work for many moms. So we really need to talk to mom about which one of these she'd be willing to start with and what she's willing to explore. And we should also mention that medication it can end up being a tricky conversation depending on who mom's providers are. There has been a lot of research into the field of whether or not the medications used for mental health, how they affect a baby, especially during breastfeeding. And at this point, I think the best thing that we can say is that we aren't sure. We think that the benefits of breastfeeding outweigh any possible risks, but that's still a tricky conversation. And I think we have to be real open and honest about that. So that's a conversation that mom needs to have with her doctor. And you want that doctor or that medical provider to be someone who's up on the latest research. There are certainly years ago, medical providers would just say, okay, take this medication and do not breastfeed. That is not what medical providers are all saying right now, but there are those out there who are still saying that. So this is a really tricky way of saying that the conversation around medication is important, and mom needs to have that with a provider. And it is a conversation. It's really not cut and dry about what would work. But certainly in cases of extreme psychosis, medication might be, and not just extreme psychosis. With depression or anxiety, medication is often a very common and very useful treatment. So it's not something that you should not consider. It's something to consider. Options for referral. So when you think about having that conversation with mom about treatment as far as community support, therapy, medications, sort of figure out for yourself, where are your referrals going to be? If you're a community health worker, you're out in the neighborhood, where are the places that you think mom should go? And then practice how that conversation would go. So, you have ideas in your mind about doctors you think she could see, or therapists, support groups that are around, or family home visiting. And then think about, how would you start that conversation? How would you say, well, who is it that you want to see? Who would you be willing to see? With the medical provider, these moms most likely have been seeing either an OB or a midwife very recently. So they have actually kind of a variety of medical providers they could go see. So you may suggest to the mom that they go see their OB or their midwife, or their family practice doctor, the doctor that they were seeing before they were pregnant. Or you might suggest, if they are currently seeing a therapist, or if they had a therapist in the past, to go back to that therapist and just say, look, this is really happening now and I'm not doing well. So it isn't a one-size-fits-all. It's not always send her to this doctor. It's more of helping mom determine which doctor they'd be really welcome or comfortable seeing. And if they're not willing to see a doctor, if that is not something they're going to do, then think about, was there another community support that we can get you to start doing, that maybe building those relationships, like with a family home visitor or a support group, might help mom open up her perspective to seeing a medical provider or a therapist. And it's just some barriers. And I'm sure you're all familiar with the different barriers that moms may face to seeking treatment, and certainly stigma, this idea that if you're first of all, many of our communities are not comfortable talking about mental health in general, or seeing mental health as a concern. But certainly for a new mom, are you just being lazy? Are you just being anxious? Are you just experiencing what moms are supposed to experience? So why complain about it? That's kind of what we think about in stigma. And it isn't, that's real, but it's also real to talk to moms about how this is a big deal and it could really affect your experience and your child's development. And that's why you're going to ask for and seek treatment, even if other people don't approve. And it's also an opportunity to sort of talk to, if there's a chance for the community health worker to talk to the broader family about why this is a big deal and that it doesn't have to be like this. Barriers certainly breastfeeding can be a barrier. If mom is worried about whether or not she'll get to keep breastfeeding, that can be a barrier to seeking treatment. a huge issue with mental health, and especially with depression and anxiety as well, is the disease itself, the disorder itself of being depressed makes you not want to get up and leave the home. Well, getting treatment means you have to get up and get out of your house or your home, right? So like the thing itself is what's making it hard to get treatment. So these are all just reasons why people really need the community health worker to support them and encourage them in seeking treatments. And certainly just that piece about not everyone, not all cultures, and certainly across all cultures, not all people view these perinatal mood and anxiety disorders as a disorder. They can just view them as this is just what happens. So when we talk about a warm handoff, what does that mean? That means we're not just saying, I think I see a problem here. Here's a phone number, handing them a piece of paper and being done. That's not enough. We're kind of talking about talk it through with the mom about who she'll go to, and then consider if it's a time for you to help mom make those phone calls, or for you to help mom go into a clinic, or help mom visit a therapy group, or is there a way that you can make that handoff warmer? Even, the experience of therapy itself is really scary, and it can be a new thing to someone. If you can talk to mom, and even yourself, if you can understand what therapy looks like, do we mean they're going to go in a room and lay on a couch and have to talk to someone? Are they going to go sit in a group with a bunch of other women and have to tell other people their secrets? Therapy can look really, really different. And so you want to help mom understand what the therapy you're recommending they seek looks like, so that it's a little less scary for them as they approach it. And consider even, if it's possible in your setting to be able to make the handoff to treatment or to a medical provider when you do the screening, that, the more you can make it right there quickly and person to person, the better. We do have some clinics who are able to screen moms in the well child check, and then if mom screens positive, they're able to bring a social worker in right away. That is certainly the ideal warm handoff, is to do something quickly and face-to-face. The more you have to call people afterwards or have them call people, the harder it is for moms to connect. And I should mention also, recent research has shown that moms are much more likely to participate in therapy or in treatment if they're connected to it during pregnancy than during the prenatal period. So it's just another reason to look for it during pregnancy, because you're more likely to help a mom follow through with a treatment. If you have questions, and I do want to point out that in the crisis mode, for moms who are in crisis, who are suicidal or potentially considering hurting themselves or others, it really is a crisis. It needs to be acted on immediately. Our crisis network supports in Minnesota include things like calling 911 or using the crisis connection or the suicide prevention line. If you are considering universal screening, you should be considering what your crisis plan is going to be. So if you have a mom who's presenting in crisis, what you need to do is figure out a way to care for the children and then get help. You talk to mom. Is there someone else? If the children are there with mom, is there someone we can bring in to help you during this time? Get someone in there and then make your crisis calls. Our systems are not designed for moms with small babies. And so this is the way that you help augment that system to make sure that you're supporting the mom and the family in the best way. But if that can't be done, then you just have to call 911 or you have to call the crisis connection. It's not always possible to find a way to care for the children. But if mom is in that crisis mode, you really have to act swiftly. And it's not something you can put off for a week or call back and check in on. But there are when it is urgent and you really want to help, but it's not a crisis. Mom is not suicidal, but she is very, very depressed or very anxious. Here's some other places to help. So the United Way, you may be familiar with. United Way is more of a call for any type of help. So if mom is super depressed or anxious because they're having trouble finding food or housing or things like that, that's the United Way. But we are really lucky in Minnesota that we do have the Mother Baby Hope Line and the Mother Baby Day Hospital at HCMC, at the Hennepin County Medical Center. And they do have a support phone line. Both this one and the other one I'll mention are warm lines, which means they are not automatically answered. They may have to leave a message and get called back. So that's another reason to help them with this. But both the HCMC line, the Mother Baby Hope line listed here, and the PPSM Hope line listed below are open to talking to mom about their problems, but they're also open to helping moms find a service that will work for them locally. The HCMC Day Hospital, I just can't say enough because it's just an amazing resource that we have. Moms are able to go in for day therapy, outpatient, which means they're going home at night, and they can bring their baby with them. They do therapies for the mom and the baby together. So it's really a great resource. Another thing that the Hope Line does, which is exciting, is that they will provide consultation for providers. So if you are working with a medical provider who wants to help a mom with medications, but she's breastfeeding and they're not sure what medications to use, the Hope Line there's a doctor on call with the Hope Line who can provide medical consultations. The Postpartum Support Minnesota resource list has more of a list of therapy groups, therapists, like individual therapists who are trained for postpartum depression and anxiety, but also groups. Both of these resources are used statewide, but certainly have more resources within the Twin Cities. And you should experiment with them. So even before you have a mom that needs help, you can go on these websites or call these people and say, okay, in my neighborhood, say I live in West St. Paul, if I ran into a mom here who needed support, what would I refer her to in West St. Paul? You can go ahead on those websites and look to see what resources you think we would use. The Postpartum Support Minnesota, or PPSM, is part of there's a national network called Postpartum Support International, or International Network. And what's kind of cool about that is they actually have a whole page. They have a whole website in Spanish. And so if you have people who are reading Spanish, you can go to that website and get all the information just in Spanish. The other thing that I think is kind of interesting about what they're doing is that they recently added a text line. So if you have moms who would reach out for help but would prefer texting or don't have talk minutes and they only have texting minutes, they can use this texting line. And I just want to mention that you should be thinking a little bit about the future for when to screen with the child. If the mom does screen positive for mental health concerns, consider ways that you can support making sure the child is screened for future developmental or social emotional concerns. Through our state's Help Me Grow system, anyone can refer a child to getting screening, and you can do that. They have screening tools that work as early as 2 months. They're certainly at 4 months or 6 months. So if mom appears to have a mental health concern and appears to have had one for a while without treatment, then any way that you can encourage mom to get her child screened as well would be really helpful. So this is the time where if we were live, I would ask you for questions. So I will just say if you have questions, please feel free to email or call me. Again, I'm Tessa Wiegin with the Minnesota Department of Health. And you can go on our website there to see links to a number of these resources and certainly all those the postpartum and anxiety fact sheets, brochures, and the maternal well-being plan. Thank you all for your time, and I really appreciate the efforts you're making in helping women maintain and gain positive mental health.